Welcome to Washington Hospital Today, dedicated to informing residents about healthcare topics and issues. Through programs featuring community forums and free health and wellness classes, our goal is to empower community members with the information needed to make informed health decisions. Washington Hospital has been providing healthcare to the residents of the Washington Township Healthcare District for the past 60 years. Hello, welcome to today's presentation, Diabetes, Understanding and Controlling Complications, presented by Dr. Prasad Katta, endocrinologist with Washington Township Medical Foundation. Dr. Katta is the medical director of the diabetes program at Washington Hospital. He completed his residency in medicine in Great Britain and obtained the degree of MRCP, member of Royal College of Physicians. He obtained residency in internal medicine at University of Medicine and Dentistry in New Jersey and fellowship in endocrinology and metabolism from Charles R. Drew University. Dr. Katta is board certified in internal medicine and endocrinology. His interests include diabetes, thyroid, and osteoporosis. Please welcome Dr. Katta.
Hello. Thank you for attending this presentation today. So we'll be talking about diabetes overview, complications, and also medications to prevent those complications. The title is The Old and the Not So Old. That's with respect to the medications. So in this part of this talk, we'll be looking at definition and prevalence of diabetes, touch upon the complications. This is not a talk completely about complications. And we'll be looking at what is ABCs of diabetes, the medications, old and the not so old. The newer medications will be touching upon the additional benefits. We'll also be looking at the ominous octet, what that means, control of ABCs of diabetes. Just want to give you a disclaimer. This talk is for educational purposes only. Please talk to your doctor to change any current treatment or medications. Don't act upon anything presented in this presentation. So what's the definition of diabetes? It's a disorder of abnormal blood sugar levels. It's also a defect of insulin production or its use by the body. We say insulin used by the body because of, with respect to insulin resistance, though the insulin is produced, the body may not be using it as it's supposed to. So insulin is a hormone made by the pancreas to regulate blood sugar. And the pancreas, if you look at it, is situated here. Just behind the stomach and sort of in center of the abdomen. So what's the lifetime risk of diabetes for a person born in the United States in the year 2000? I know we are in 2022. It's about 1 in 3 Americans will be a diabetic in their lifetime, and 2 out of 5 African Americans are Hispanics, and 1 out of 2 Hispanic females. So the prevalence of diabetes in 2022, this is the CDC National Diabetes Report. Total of about 37 million have diabetes. That's about 11.3% of the US population. Diagnosed is about 28 million and undiagnosed is about 8.5 million. And with respect to pre-diabetes, the numbers are actually pretty sobering or staggering, you should say. Total is about 96 million. This is people who are 18 or older, and that's about 38% of the US population. And 65 and older, we have about 26 million people who are 65 or older who are pre-diabetic. So what are the risk factors for type 2 diabetes? Inactivity, race is definitely a risk factor. Hispanic and South Asians definitely are higher risk. Pregnancy because of its insulin resistance, because of the placenta produces the hormones which makes the woman more insulin resistant during that time. Obesity, high stress, and family history is definitely a risk factor. Certain medications can also be a risk factor, and age over 65 is a risk factor. So why have we developed diabetes, or why is diabetes more prevalent over the last 30, 40 years, and it continues to be that way? It's the evolution of mankind. It's mainly, we started as a hunter-gatherer for the last 2.5 million years. And over the last 50 years, we have pretty much come down to the couch potato with the fast food and so not being active. So with respect to diagnosis of diabetes, if you look at the fasting blood sugar, the normal is less than 99, and pre-diabetes or impaired fasting glucose is between 100 and 125, and diabetes is greater than 126. Or if you have a A1C, which is the average blood sugar for the last 2 to 3 months, greater than 6.5, then someone is considered diabetic. On the American Diabetes Association says on 2 separate occasions, but a lot of times we tell patients that more than likely they are diabetic even on one occasion, and if they want to get retested, they can, and then we'll make the diagnosis of diabetes. What are the potential complications of diabetes? If you look at this slide, it shows heart disease and stroke, which is the most common cause of death in a person with respect to diabetes. Kidney disease, which can lead to kidney transplantation. Eye complications, including blindness. Diabetes in US is the most common cause of blindness with respect to eye complications. Diabetic neuropathy, where the nerves are affected due to the high sugars, that can lead to foot complications, skin complications, and amputation. Gastroparesis, which is actually slowing of the stomach, that also is because of neuropathy. Depression and infection, they are probably secondary complications of a person who has diabetes. So this slide basically shows the 3 microvascular complications, we call that. That is the vessels which are small, supplying the blood vessels which are small, which is supplying the kidneys, the eye, and also the nerves. They get affected when the blood sugars are high, and that leads to nephropathy. That's a microscopic slide which shows that the changes in the kidney. The retinopathy, which we look at the flame-shaped hemorrhages, this is here and here in the person who's not controlled with diabetes. And the neuropathy is where they've lost a couple of toes here. And also you see the foot is deformed. The reason the foot is deformed is they don't have sensation. And when they don't have sensation, a person can have fractures and the foot can get deformed. So this is a slide which shows that cardiovascular risk increases as a comorbid condition with diabetes, and also with respect to kidney disease. The bars in the blue are the normal patients. The one in the orange are patients with diabetes, and one in the red are patients with diabetes and kidney disease. If you look at it for all these, this is heart failure here. This is myocardial infarction or acute myocardial infarction. This is stroke or TIA, which is usually the stroke symptoms resolve within 24 hours. This is peripheral vascular disease, and this also is atherosclerotic cardiovascular disease, and this is death. Anywhere from if a person is normal to if the patient has diabetes and kidney disease, it increases double to triple across the board. So causes of mortality in patients with diabetes, if you look at it, heart disease, cerebrovascular disease, and diabetes almost accounts to about 80% of the patient's cause of death in a person with diabetes. The other conditions include malignant neoplasms, pneumonia or influenza, and other causes. So what we need to do is, when we are treating patients with diabetes, we need to try and prevent this heart disease or cerebrovascular disease and the other complications of diabetes. This is definitely scary stuff, but at the same time, you have medications to treat diabetes. The treatments are much better than 10 to 20 years ago. Many cases, type 2 diabetes can be controlled for a long time without complications, and we can definitely prevent heart disease and stroke in the long run. So what are the ABCs of diabetes? A stands for A1C. A1C is the blood glucose check with a memory of over the past 2 to 3 months. B stands for blood pressure, and the American Diabetes Association recommends a blood pressure below 130/80. And C stands for cholesterol, and the cholesterol which we concentrate on is the LDL, which can clog your blood vessels and lead to heart disease. HDL, which is the good cholesterol, protects your heart. So taking it a little further, D stands for diet, E stands for exercise and eye exam, F stands for foot exam, G stands for glucose monitoring, and H stands for health maintenance, where you'll get your other health maintenance like breast exam, colonoscopy, and other things. What medications are we to use? We definitely have a lot of plethora of medications right now, because if you had diabetes in the 1970s or 80s or even in the 1990s, we didn't have that many medications. So we definitely can take care of type 2 diabetes without any major problem as long as the patient is compliant. Type 1 diabetes is always insulin, and type 2 diabetes is a combination of pills, insulin, and other injectables which are not insulin. Medication selection depends upon the patient, where they are with their blood sugar control, whether they're newly diagnosed or not, or whether they've had disease for 5 years, 10 years, and what they have tried. There are many new medications in the market in the last 10 to 15 years. And the three main categories, we have oral agents, there are different kinds, old and new, insulin, newer and more modern insulins, and then non-insulin injectable medications, which are not insulin but are still injectables, and they can be either taken once a day or once a week. The choice definitely is a lot, and it allows individualization of the treatment plan, and we can cater it to what the patient wants or what the patient needs. So if you look at this slide, I've just put this medications old, which I've said from 1982 to early 2000s. We have biguanides with metformin, which is most commonly used as a first medication in treating diabetes. Sulfonylurea group, which is the medications is glipizide, glimepiride, and glyburide. We also have pioglitazone or Actos, and we have the meglitinide group, which is the natiglinide and ripaglinide, which usually needs to be taken 3 times a day. Alpha glucosidase inhibitors, we rarely use them. Insulin, long and short acting. The new and newer medications, or not so old medications, since 2005 or later, the DPP4 inhibitor group, we have Januvia, Onglyza, and Tregenta. And we have the GLP1, the names are there. You may have seen advertisements on TV for this, Trulicity, Ozempic, Rybelsus, which is an oral medication, and the newer one is Mounjaro. And SGLT2 inhibitors, which work on the kidneys, Invokana, Farxiga, Jardiance, and Steglatro. Insulin long-acting, the newer ones are Toujeo and Tresiba. And the short-acting, we have as Epidra, Fiasp, Admilog, and Lumjev. And the combination of insulin and GLP-1s, we have 2 of them, Soliqua and Zultofi. And we also have bromocriptine, which is name is Cycloset. So I wanted to show you this slide, the ominous octat. If you look at here, what in the center of the slide, this is hyperglycemia, which is high blood sugar. And there are different reasons for high blood sugar. One is the insulin not being produced enough from the pancreas, too much blood sugar from the liver, and also you have the increased glucose reabsorption from the kidneys. The kidneys filter the blood sugar and they reabsorb it. That also causes high hyperglycemia. You also have the fat breakdown in the fatty tissues. The incretins, which is the non-insulin injectables, with the GLP1 analogues, they are produced less in the intestines, and that also leads to hyperglycemia. And the last one is the neurotransmitter dysfunction, which is the GLP1 acts on your brain to make you more full, and in diabetes you lose it. That also can cause hyperglycemia. So all these causes, all these defects actually cause hyperglycemia. So you can't treat diabetes with one medication, especially if a patient has had disease for more than a few years. So I'll be going over these medications. The Metformin is a generic medication. Doses are 500, 850, or 1000, and the maximum dose is 2000. Extended release is 500 or 750 mg. It has to be taken usually after eating twice a day or once a day if it's extended release. Usually we build up the dose to minimize the side effects. The side effects are mainly bloating and loose stools. These are usually large pills, and person usually doesn't gain weight. It's weight neutral. It works on the liver to produce less glucose when not eating. And if the kidney functions are an issue in a patient, we may need to decrease the dose. Some of the myths about metformin: it causes kidney issues. That's not true. It causes cancer. That's not true. And sometimes in the last few years, you may have heard that or heard on the news saying that metformin is being recalled based on the manufacturer, etc. So if that's the case, it's usually because of a substance called NDMA. You call your pharmacy. You can call your physician, but the physician won't know which batch the pharmacy has dispensed to you. So best to call the pharmacy and ask them. And if they say it is one of your batches, then you may have to get a replacement. The sulfonylurea group is a generic group. Again, glimepiride, glipizide, and glyburide. This has to be taken usually 5 to 10 minutes before eating. It works on the pancreas mainly directly to produce insulin. The low sugars are one of the main side effects if not taken with meals, or if they miss their meals, or if they don't eat enough. Weight gain can also be a side effect. We definitely have to be careful in the elderly and also when the kidneys are not working well, because it can cause low sugars. So the meglitinide group, these are two medications, the ripaglinide or the natiglinide. It has to be taken 5 to 10 minutes before meals, usually 3 times a day before eating, acts only for 2 to 3 hours, and low sugars can be a side effect, again, if you're not eating enough. So Actors or pioglitazone, this is usually a once a day medication. Usually the dose we give is 15 or 30 milligrams. It acts on decreasing the insulin resistance and helps your body to use your insulin better. Can cause weight gain and leg swelling. Cannot be used in patients who have a history of heart failure, because it can cause fluid overload and push them into heart failure. And it can also cause bone thinning, very small chance of bladder cancer with high doses. Again, this is not a very well-known sort of side effect, but it can happen. So we usually use 15 or 30 milligrams. The alpha-glucosidase inhibitors, which is the acarbose, this medication rarely used. It's also a generic medication. Needs to be used 3 times a day with meals. And the gastrointestinal side effects like gas and bloating are prominent. Again, I just put the ominous octat here. The reason is I'll be talking about these GLP1 and the SGLT2s in more in detail, and also the DPP4s. So the DPP4 inhibitors, none of the group of medications, none in this group are generic. The names are Januvia, Onglyza, Trajenta, and Nesina. They've been there for at least 17 years, if I'm right. They came out in 2005, at least a couple of them. Works on the pancreas indirectly to produce insulin and decrease glucagon. Usually we take it once a day. It's a weight neutral, does not cause low sugars. Side effects are minimal and can be used in the elderly. None of these medications are generic and can be expensive, and very rarely inflammation of the pancreas or pancreatitis can happen, where you'll have a real bad pain in your center of your stomach or your abdomen, and we would definitely want you to stop the medications at that time. And if someone has a history of pancreatitis, we will not give the medication. So these are the non-insulin injectables, or the GLP1 analogues. None of these are generic. The once a week are more widely used nowadays. We have Trulicity once a week. Bydureon we rarely use now. Ozempic once a week, and Mounjaro, which is a newer one, which has both GLP, which is the glucagon-like peptide, and GIP, which is gastric inhibitory peptide. These work mainly on the pancreas indirectly. It has both the actions. And the once a day is Victoza, and twice a day we don't use it anymore, Byetta, but that was the first medication which came in this group. None of these are generic, the GLP1 analogues. They're called non-insulin injectables. They work on the pancreas indirectly to increase insulin production and decrease glucagon production. The glucagon is a medication or a hormone which actually raises blood sugar, and we actually use it when patients have low blood sugars. So in a person who has diabetes, there is increased production of glucagon. So these medications actually decrease the glucagon production. So it lowers your blood sugars. It makes a person feels full by slowing the stomach emptying, and also acting on the brain to make a person not feel hungry. It can definitely cause weight loss, and some of them can prevent death due to heart issues. I'll be talking about that later. Nausea and vomiting are the most important side effects. It can cause inflammation of the pancreas, like pain in the stomach, as I explained earlier. And very rarely it can cause a certain kind of cancer in the thyroid, but it has been only observed in rats and mice. So still important to know if there is any family history of this. Newer medications with respect to the GLP-1 analogues, the additional benefits. All of these medications are approved for control of blood sugars. Okay, and 3 of them at this point of time, Victoza, Trulicity, and Ozempic, are approved for prevention of death due to heart issues. So that's definitely a plus point in using these medications. SGLT2 inhibitors, none of these are generic. Invokana, Farxiga, Jardiance, and Steglatro. They use kidneys to eliminate sugar in the urine. It's a once a day medication, usually taken in the morning before breakfast. You need to drink more water. Otherwise, you can get dehydrated, and there can also be fungal infection of the private area. That's a side effect too, and it can cause weight loss. So with respect to additional benefits of this group, if you look at it, all of these are approved for control of blood sugars. With progression of kidney disease, couple of them are approved, Farxiga and Invokana. With respect to heart failure prevention, Jardiance, Farxiga, and Invokana are approved. And with respect to death due to heart disease, Jardiance, Farxiga, and Invokana are approved. So that's additional benefits of using these medications in addition to controlling the blood sugars. Cyclocet, this is a medication which is not generic. It's used once a day, usually taken in the morning. We start usually with 1 tablet and build it over the next few weeks up to maximum of 6 tablets. It works on the brain to help you use your insulin better. And headache and dizziness are the most common side effects. I wanted to just talk about this medication Kerendia, or it's also known as Finrenone. It's a new medication. It's for patients with type 2 diabetes, but it does not lower your blood sugars. So how does it help patients with type 2 diabetes? It prevents progression of kidney disease in type 2 diabetics, and also prevents heart failure and death due to heart failure in type 2 diabetics. It works on adrenal gland receptors. The adrenal glands are 2 glands which are situated above your kidneys, and it works on the receptors there. And definitely a good medication to use if you have any kidney disease, to prevent the progression of kidney disease, and also with respect to prevention of heart failure and death due to cardiovascular issues. So when to use insulin? There's no right answer to this. It can be used at any point when the sugars are not controlled. Most patients and physicians tend to try to use insulin later on in the disease process. That always is not a right way to go, but you can use it at any time. There are 2 types of insulins, long acting, which is once a day, and short acting. Usually most of the time we use it 3 times a day with meals. So these are some of the names of the insulin. Most of them you may have heard it. Some of the newer ones, when I say newer ones, has been there for at least 8 to 10 years. Toujeo and Tresiba, and the short-acting ones are the Fiasp and Lumjev. And these are the pre-mixed insulins. We very rarely use them nowadays, but still some patients can be on it. Checking your blood sugars. Again, taking the blood sugar monitor and your logbook to the physician office is very important. Most monitors can be downloaded in the physician's office. Important to check it at different times of the day. You want the patients, especially patients who are on insulin, the blood sugars act as a story. If you don't check your blood sugars, it's like watching like a still photograph versus like watching a movie. And again, I usually tell my patients, if there is no pain, there's no gain. Goals for the blood sugars. There are two, the ADA and the American Association of Clinical Endocrinology. In the morning and before meals, the ADA goal for the fasting sugars are less than 130, and the American ACE goal is 110. After meal, it's less than 180, the ADA goal, and the ACE goal is less than 140. Usually the ACE goal is more stringent, and their A1C goal is less than 6.5, and the ADA goal is less than 7. Nowadays, we are also using sensors. So glucose sensors can be used. I've shown a couple of sensors here. One is the Freestyle one, the other one is the Dexcom one. And we usually use them to look at the trend of the sugars. And at times, just the blood sugars may not tell us a full picture. This is a graph of a CGM, or continuous glucose monitoring graph of a patient. If you look at it, 74% of the patient sugars are under control. 20% is high, 5% very high. And you can see here, this is the 12 a.m., 12 p.m., 12 a.m. here, and 6 a.m. and 6 p.m. It's high after dinner. So if you're looking at after dinner, so we'll have to tell the patient that we need to try and control our sugars after dinner. And this is a patient where 88% of the sugars are controlled and about 7% high. And their A1C, according to this, is 6.3. This is called the Glucose Management Indicator, or GMI, and that tells us a good picture of the A1C. This is another CGM graph. If you were just checking your sugars in this patient here, 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 or here, you would have thought that the patient's blood sugars were very good. But if you're looking at the graph, you definitely know that the patient's blood sugars are not good, because they're high it's going high after breakfast and to some extent after dinner too. So as the A1C goal gets closer towards the goal of 7, we need to control the postprandial sugars of the after meal sugar significantly better, or it does pay more importance. So if you look at it here, the A1C is 10.2, and majority of the contribution to this A1C is the fasting sugars as the fasting plasma glucose. And as you're coming towards less than 7.3, majority of the contribution here is the postprandial or the after meal sugars. So anyone below 8.5 or 8, they need to check their sugars more often after eating. And that applies to pretty much any point in time in diabetes, but that's more important in patients whose A1C is less than 8.5. So about your A1C measures the average blood glucose over the last 3 months. You get your A1C checked at least twice a year if your sugars are controlled. Go less than 7 for the ADA as long as you don't have any low sugars and you're able to tolerate the 7 as your A1C. Preferably less than 6.5, that's usually the ACE goal, or American Association of Clinical Endocrinology goal. Now, again, we talked about the ABCs of diabetes earlier. So just the explanation of A1C. A1C is the marker which we use with respect to treating diabetes in most patients. It's basically the red blood cell gets coated with the sugar, and over the next few days to weeks to months, maximum is like 2 to 3 months, the more coating of the blood sugar is there, the higher your A1C is. So it's very well known to for the patients to sort of ask your A1C. So always when you go to your doctor, you want to ask them, okay, what's your A1C and where you are and what's your average blood sugar, what it corresponds to. So this is the average blood sugar correspondence with respect to the A1C. If you're 5, you're 97. If you're 7, you're 154. If you're 9, you're 212. And if you're 12, it's high, 298. And if you're 14, it's 355. Definitely want to be as much as possible below 7. How often to check the A1C? Usually every 3 months if not controlled or adjusting medications. Every 4 to 6 months if you're stable and you're not adjusting medications or no new medications are started. So do we just give an A1C of 7 across the board and that's the goal for everyone? Not necessarily. The reason is because it depends on various factors. And this is the American Diabetes Association Standards of Medical Care in Diabetes slide. If you have a risk of hyperglycemia or other drug adverse effects, you probably are less stringent. If you don't have any, then you're more stringent. Duration of disease, again, if you have had it for 30 years or 40 years, you're probably less stringent. If you're newly diagnosed, you're more stringent. So it grows across the board here. Life expectancy is the same. If you're more comorbidities or more complications, then we probably are less stringent. If you have vascular complications, you're less stringent. And also patient's attitude and expected treatment efforts. If a patient says 7.5 is what they would want and they don't want to go any lower, you will have to respect it. And also resources and support system, if that also plays an important role, because if you have like a 85 or a 90-year-old man or a gentleman or a lady and they live by themselves, you don't want to sort of be too aggressive in treating their diabetes. Blood pressure. So B stands for blood pressure in the ABCs of diabetes. Up to 20 to 60% of the adults with diabetes have high blood pressure. Definitely it's an increased risk for kidney disease, heart attack, and stroke. And the target blood pressure for diabetics as per the ADA is 130 by 80. And the key steps for lowering blood pressure, again, eat more fruits and vegetables, reduce your salt, lose weight, lower your alcohol intake, quit smoking, take blood pressure medications if needed. And many people require more than one pill to control their blood pressure. And these are some of the names of the blood pressures. The two groups which we most commonly use in patients with diabetes is the ACE inhibitors and the ARB, which replaces the ACE. And these are some of the medications. The other ones are beta blockers, calcium channel blockers, and diuretics. There are other agents too. I didn't put all of them on this slide. C stands for cholesterol. And often it is abnormal in adults with diabetes. Again, increased risk for heart disease, stroke, and amputation. And the new guidelines basically say, when I say new guidelines, it's been there for at least like last 7-8 years. Every diabetic needs to be on a statin, does not matter where their cholesterol is. So even a low dose statin is good enough. So the cholesterol targets in diabetes, the bad cholesterol or the LDL, usually it says 100, but again, most patients with diabetes are considered high risk. 70 is usually the goal. I like personally for patients to be less than 70. The triglycerides is the other number we look at, which is less than 150. And the HDL cholesterol, usually we want it to be above 40 for males or 50 for females. We also look at non-HDL cholesterol, but that only if your triglycerides are high and the HDL is at goal. Then we can calculate that by taking the total cholesterol, subtracting the HDL from it, or taking the LDL, which is the bad cholesterol, and adding 30 to it. Again, key steps with respect to that: eat food which are high in fiber, example, oatmeal, beans, peas, and citrus foods, less saturated fat, and also taking a cholesterol medication, exercise regularly. Usually exercising increases the good cholesterol and also to some extent decreases the bad cholesterol. And this is a slide for portion control, just a handy guide for portion control. If you're looking for poultry or meat, you want 3 ounces, your palm. Fist is the rice, pasta, any carbohydrates, fruit, veggies, or ice cream is a cup. A cupped hand is half a cup of beans or potatoes. 2 cupped hands is like a snack, chips, popcorn, or pretzels. 1 thumb size is the peanut butter or hard cheese, and thumb tip is cooking oil, mayo, or butter. So the statins, the medications to treat the cholesterol or triglycerides, statins are the most important medications. These are some of the names: the simvastatin, atorvastatin, rosuvastatin, and others. And there are other medications too. The ezetimibe or Zetia, Welchol is another one. Fibrates to control the triglycerides, fenofibrate or gemfibrozil, and the fish oil also does the same. And niacin also controls triglycerides. And my advice to patient about exercise usually is exercise only on the days you eat. If you don't eat, don't exercise on that day. So by controlling the ABCs of diabetes, you can definitely reduce the complications of diabetes, and the newer medications definitely help you with preventing heart attacks and also progression of kidney disease. With that, I think this is the end of the talk, and I'll take any questions.
Thank you, Dr. Katta. We do have a few questions. The first question is, I'm a diabetic treated by my primary care physician. At what point should I consider seeing an endocrinologist?
Thank you for that question. So that question, again, it depends upon the patient and also the primary care physician. Means there's no general rule when you need to see an endocrinologist, but if the physician feels that they are not taking care of the patient, or they feel that the patient is difficult to take care, definitely they can refer them to the endocrinologist. And also, if the patient themselves feel, okay, no, maybe I may need to seek a second opinion just to see if everything what I'm doing is right and the doctor is taking care of me right, they can also see a endocrinologist at that time. Again, it differs from physician to physician and patient to patient. So I can't give you a definite answer for that. Okay, this is where we need to see, like, you need to be seeing an endocrinologist if you're more than 2 medications or 3 medications or even an A1C goal.
Okay, thank you. And the next question we have is, there are so many medications that you mentioned. How does my doctor determine what medications are the best for me?
Yeah, that's a good question again. So as I told you, it depends upon where a person is in the disease process. Now, if a person is very early on in the disease, we can use generic medications. We can use some of the newer medications also, and then combine with the generic medications, because the generic medications are pretty effective and they work for most patients unless they have side effects or they don't tolerate it. So as the disease progresses, and if the A1C numbers are high, you definitely can go to the newer medications and also the non-injectables. The slides which I didn't put in are a couple of slides from American Diabetes Association and American Clinical Endocrinology as to their algorithm as to where to use the medications. Pretty much any medication can be used anywhere with these 2 algorithms by these 2 organizations. So there's no set thing as to, okay, you have to use this medication at this point of time. And again, anywhere in the disease process, someone can start a new medication or an older medication if they have not tried that.
Okay, we loved your slide about only exercise on the day you eat. That's a great slide. What kind of exercise do you recommend?
I usually recommend at least some aerobic activity, 20 to 30 minutes a day. Ideally, they say at least 30 minutes a day, and at least two days in a week, you do need to do some strength training. And that can be, you can do free weights or just weights with a machine or any kind of resistance exercises, even with a band and things like that. So that would be the best way to go.
Great. And our last question is regarding different diets that we're seeing these days. Can you tell us what your thoughts are on the differences between intermittent fasting, plant-based diets, and just regular carnivore diet.
Yeah, so all these diets do work for patients, but at the same time, what you need to understand is whether a person can do it for a long term process. It should be a part of your what daily life it should be. Intermittent fasting definitely works, but at the same time, you want to make sure that you also talk to your doctor with, if you are taking medications for diabetes, what you want to avoid. You definitely want to avoid low sugars and things like that. The plant-based diets are more used for preventing heart disease and things like that. They definitely work. With respect to low-carb diets like the keto, South Beach, they also definitely work. But the most important thing is how long can you tolerate it and how long can you continue doing following the diet. With respect to the low carb, the high protein diets, one of the things you need to be one of the things you need to be aware of is they can increase your cholesterol, especially if you're consuming a lot of red meat and things like that. So you definitely want to look into that. So, but talk to your physicians, and they will definitely guide you with respect to which diet you can go on and things like that.
Great. Thank you, Dr. Katta, for your time today and for this insightful presentation. This concludes our program, and thank you, viewers, for tuning in. The entire broadcast of today's presentation will be available on our Facebook page and YouTube.